The questions to the end of the session. I now invite Dr. Vanashree Nair. She is a consultant in refractive and cataract surgery at Giridhar Eye Hospital, and she shall be talking about lens-based refractive procedures, namely clear lens extraction.
Thank you, Dr. Swapna ma'am, for making me a part of this IC, and a very good morning to everyone here. So basically, refractive lens exchange, what is the role in spectacle independence is the talk that I'm giving today. So basically, we are removing the clear lens here to correct high refractive errors or presbyopia. So what is the role in today's practice? Just now we heard Dr. Adityan speak about presbeyond going way beyond the previous days and doing well now. So there are still some, criteria where you may find this a better option. So age and the refractive error is what actually matters when you're taking a decision. So very high refractive errors, like very high myopes or very high hypermetropes, which may not be amenable to LASIK or even ICL, IPCL for that purpose. And when you're looking for a permanent solution for presbyopia, this is becoming a very popular term called as prelex, which is being used by surgeons as an option to give to the patients as a treatment, a permanent treatment for presbyopia. So, as refractive surgeons, the first thing we think of is the cornea-based procedures. If that is not possible, we go to ICL. If that is not possible, then the last option left is refractive lens exchange. Why it is the last option? Because it's an invasive procedure, obviously. So compared to laser procedures, the risk of retinal detachments, endophthalmitis stars, vitreous loss, which is similar to cataract surgeries, that risk is there. So that is the con. The pros is basically relatively a permanent solution that the patient thinks that he'll not going to develop cataract later on. So at one step your thing is done. I'm free. So that becomes a pro. Now coming to really very high myopes, the things that we need to keep in mind or consider is that we need to get the retina thoroughly checked, because if the PVD has not already occurred, then there is a increased risk of retinal detachment in these patients, and in a clear lens young patient, risk of RD can be quite disheartening. So a prophylactic barrage laser may be required if there are these minor changes in the periphery. And the type of IOL will again depend on the lifestyle requirements of the patient. Hypermetropes, yes, they have an advantage with clear lens extraction because these are smaller eyes. So many a times you don't have the AC depth for the ICLs. And laser procedures, as we know that there are higher chances of induced higher order abrasions in hypermetropic corrections. So this could be a good option. But if they are really small eyes, then again choroidal effusion is something that we need to keep in mind and keep a vitreoretinal surgeon backup as well, if need be. Presbyopes, not the late 40s and early 50s. These patients have clear lenses, but they have lost accommodation, and some amount of dysfunctional, lens syndrome is already set in, which cannot measure on the Snellen's chart. But if you see the contrast sensitivity, it has probably dropped. So these patients who are looking for a permanent solution to reading glasses, again, prelex is an option. Going to the biometric consideration, it is similar to cataract surgery when we are offering a premium IOL to the patient. It is same over here that we have to keep an eye. But again, here we are dealing with really long and short eyes. So we need to be careful with the biometry that we are going to look into and the formulas that we are going to use. So also take multiple readings so that we are sure about what we are calculating. So we have the modern optical biometers are really doing a good job in compensating for the posterior corneal astigmatism. Some are calculating in the true corneal astigmatism like the IOLmaster 700. And of course, we have good online formulas available now, which give us the confidence that we are putting in the right lens. So I'll just, So going to the toric considerations, since we are exchanging the lens over here, so we have to be sure that the astigmatism is corrected in a precise way. So there is a small consideration that the cornea, as it ages, will go from with the rule to against the rule astigmatism every 5 years. So it is the anterior with the rule astigmatism that shifts towards the against the rule astigmatism. So it is better to target a slight amount of with the rule astigmatism, around 0.35 is what they're saying when you're operating younger patients. Again, do your eye trace or corneal tomography to confirm how much is the corneal higher order abrasions for spherical abrasions. check the chord mu, because here you're going to put a trifocal IOL. It better be centered well to prevent the glare and halos that might come up. Various options are there depending on the patient's liking. So you'll rather go for a trifocal, or sometimes the newer EDOFs, which are doing really well for the patients. So I won't go into the details of these, but one point I would like to mention is when you're operating hyperopes, they have high angle kappa. So the problem of glare can come here. So ensure that your chord mu or the angle kappa is within 400 microns here. So this is a diagrammatic representation, like if you can see the pupil center at number 2 over there, and at number 1 where you have the visual axis. If the chord length between them is more than 0.5 or 0.4, then you may have the problem of glare and halos. So this is just a comparison between the two IOLs. Whether if there's a larger bull's eye in the center, then the problem of glare will be less, but that has a lesser add power. Coming to the intra-op considerations, so we are operating on relatively younger patients, so remember that the sclera is going to be soft capsule, so the rhexis may be a little difficult. Better to use a forceps to have a well-centered rhexis. Soft nucleus, not much phacoenergy required. Eye may be just enough to take it out. Again, very high myopes, the lens iris diaphragm retropulsion can occur. That causes discomfort to the patient during topical anesthesia. So just before you before you start your irrigation, just lift up the edge of the iris so that the diaphragm doesn't go down and there's no reverse pupillary capture. So refractive lens exchange can be one option in your armamentarium if the patient is right and it has a healthy ocular surface. Just some contraindications to remember: if there are any corneal pathologies, uveitis, uncontrolled diabetes, uncontrolled glaucoma, previous keratorefractive surgeries, then these patients are not for lens exchange with a trifocal or an EDOF lens. So to summarize, again, realistic expectations: check all the calculations twice or thrice. Do your biometry on a fresh tee, so that when there is no surface manipulation. Thank you.
Thank you very much.